Welcome to an overview of the neurological examination, detailing the essential steps and techniques used in clinical assessment. The neurological exam is a systematic assessment of the nervous system, used to localize lesions, whether they are in the brain, spinal cord, or peripheral nerves, and establish a baseline for patient monitoring. We begin with the mental status examination, or MSE, which assesses the patient's higher cortical functions. The first step is checking the patient's level of consciousness, typically using the Glasgow Coma Scale, or by simply describing their state, such as alert, drowsy, or comatose. Next, assess orientation to time, place, and person. Evaluate cognition, including memory and reasoning, and listen for any speech difficulties like aphasia or dysarthria. The cranial nerve examination tests each of the 12 cranial nerves to evaluate brainstem function and special senses. We test visual acuity, visual fields, and the pupillary light reflex. We also check eye movements using the H pattern to assess nerves 3, 4, and 6. Test facial strength and movements, such as smiling and frowning, for nerve 7. For nerves 9 and 10, check palate elevation and the gag reflex. Finally, test the tongue's movement and strength for nerve 12. The motor system examination evaluates the integrity of the motor pathways from the brain to the muscles. Begin by inspecting the muscles for atrophy or wasting. Look closely for fasciculations, which are small muscle twitches, or any noticeable tremors. Assess muscle tone by checking resistance to passive movement. Grade muscle power on the MRC scale from 0, meaning no contraction, to 5, which is normal power. Next, check deep tendon reflexes, including the biceps, triceps, patellar, and Achilles. We are looking for symmetry and the level of response. Hyperreflexia and a positive Babinski sign suggest an upper motor neuron lesion. Conversely, hyperreflexia suggests a lower motor neuron lesion. The sensory system examination is crucial for identifying patterns of sensory loss across different dermatomes. To test the spinothalamic tract, we check for pain using a pinprick and assess temperature discrimination. For the dorsal column pathway, we test fine touch, vibration sense using a tuning fork, and proprioception, which is joint position sense. Finally, we assess cerebellar function and gait to evaluate the patient's coordination and balance. Coordination tests include the finger-to-nose test to check for dysmetria and rapid alternating movements. For the lower limbs, perform the heel-to-shin test. Observe the patient's normal walk, tandem gait, and the Romberg test for sensory ataxia. These observations help detect subtle balance and coordination issues.